of the leg. This kind of leads us into our first review question here. I got a 68-year-old male with history of stroke, presentation for routine follow-up. Upon exam, the patient's gait, you notice left-sided weakness, the patient circumducting the left leg, so it's kind of sweeping out and around as he's walking. That leg, it's spastic, it's not quite working right, he's kind of swinging it around. I'm doing it for you guys, I don't think the juniors are able to see it. And he's holding his left arm in kind of a fixed position, kind of close to his chest. What do we think of that? Dinosaur arm, upper motor lesion, so kind of fits with having a hemispheric stroke. Which is the term that best describes this kind of gait? We talked about myopathic, diaparetic, hemiparetic, that steppage gait where you're kind of stepping high, I think more CMT. And then Parkinsonian, I think Parkinson's disease. Which one is the correct answer for this one? We feel pretty confident about that. I know a lot of the gaits had a lot of different information. I can't give you an image showing a gait and saying, hey, describe it in a test, but we're gonna use some of those descriptors. There's gonna be some other things. Don't dig too far into it and say, well, the arm is abducted but externally rotated. No, just be able to grossly recognize, hey, this lines up with this kind of pathology. That's about the level of gaits. That and being able in clinical practice to see it and say, that man has Parkinson's. Cool. All right, another thing that we talked about was some of those spinal cord lesions. And I know that got a little bit scary for a little bit because you're like, all right, there's 3 different tracks. One of them's going up, one of them's going down. Some of them are desiccating at different levels. End of the day, if you want to memorize it by the different spinal cord lesion types, we'll get there together. So I got a 36-year-old woman presents to the emergency department following a motor vehicle accident with symptoms concerning for a spinal cord injury at about L1. On physical exam, the patient has diminished motor strength and diminished fine touch, position, and vibration sense on the side of the injury, but loss of pain, temperature, pressure sensation on the opposite side of the injury. What is the most likely injury? So we talked a couple of different ones. Central cord syndrome, what does that one cause? That's that crossover that happens immediately for the spinal thalamic. It only exists on that level. It's that like cape-like distribution of loss of pain, temperature, pressure. It's not on both sides. It's kind of opposite sides. So we know central cord is out. What about that transverse? What presents with that when the whole cord is out? Everything's down both. Is that what we're describing here? No. What about that posterior cord syndrome, those HDMI cables in back, that fine touch and that 2-point discrimination? Is that what we're describing here? Is the whole thing out below or no? No. And that anterior cord syndrome, well, I'm not really thinking bilateral injuries down below. You can break it out however you want. Does anyone remember what Brown's-Card syndrome is also called? That half? Is that what this one is presenting as? Cool. Are you guys able to walk through that one? Is that still kind of scary, or you kind of see the beginnings of it? I know when you deal with the cord injuries, it's a little like overwhelming. This is kind of the level we're talking about. Patient presentation, name it. Or name of a cord injury, all right, what's it gonna present as? And being able to walk through, because a lot of times you're like, I don't really remember Brown's-Card, but all these other ones don't present like that. You can work your way into it. There's a very limited number that we have to pick from. You guys, honestly, like the feedback from you guys in class, you guys were getting the cord injuries pretty well, like answering some of the questions. I'm proud of you guys. It's a really difficult topic. I don't think I got it while I was in PA school. All right, we know we're gonna have questions on MS because it's super common and I love writing test questions about it. You're gonna see it in clinic. We remember from the relative hand raises that we see people presenting with us. So I got a 30-year-old male presents with painful monocular vision loss. What's the term for that? And we have that desaturation, that optic neuritis. And we have a family history of multiple sclerosis. Well, I have a diagnosis there. You're suspecting this patient has MS. Upon taking a history, the patient admits to a long-standing heat exercise intolerance. What best describes his findings? Now I'm just looking for straight recall. You can ignore all that other history. Hey, in people with MS, what's that finding or symptom when, hey, I can't tolerate being in heat anymore? Brudzinski's, is that one out completely? Because that's something else completely. What about Koenig's sign? Same, right? We're dealing with people where we're bending the knee, we're looking for meningeal signs, it's completely out. What about Hoffman's sign? That's kind of a weird one. I don't even think we mentioned that one in class. You can throw that out completely at this point. So I'm down to on that side, either having Lahermit's sign or Uthoff's phenomenon. Does anyone want to take a stab at which one we're dealing with? Do we feel good about that one? I know that's kind of a smaller detail within there. There's some images, but that's kind of like the big ticket, like, hey, this is a very easy test question. This pops up in the pants all the time. Being able to differentiate those two. Can anyone tell me what Lahermit's sign is? We flex our head down like we're a hermit and we're trying to hide from public, but then we have that shocking electrical symptoms going down. All right, that does it. Do people feel better about those kind of review questions? Is that about on par for what I would expect? Okay, cool. We're gauging each other. I know we've had some scary tests as of late, so I try to give you guys some like baseline. All right, don't be nervous about neurology. No one studies well when they're nervous about things. I say that and then we jump right in. All right, from current slide. All right, today we got 66 slides to get through, so we'll have a little bit of time back for you guys unless I talk really slow. We're going to cover some of the cranial nerves. There's a couple of odd slides in here that are kind of background stuff, so I say, hey, cross this out, ignore it. You can go through it if it's supplemental or helpful. I'm not going to base a test question off that one single slide. All right. Real quick, some of the big things we want to talk about here. Let me pull up my laser pointer. I got the transient monocular blindness. I got Argyll-Robertson pupil. Has anyone ever heard of some of these ones before, or are these all brand new? Where'd we get this one before at? Literally like the day before, 2 tests ago. Okay. I love it. There's some of them you guys hate. You're like, I don't want to talk about dirty Argyll. Argyll socks, business socks. That's how you know it's business time. That's how I remember it. All right, pituitary tumors, which we talked about a little bit before, and we'll go into some more images so we understand what bitemporal hemanopsia is. I got giant cell arteritis, and I know we're kind of hazy about getting into vasculitises. This one's a pretty easy one. It stays within neurology, so don't worry if you haven't been exposed to that before. Tic-Douloureux, also known as trigeminal neuralgia. I got facial paralysis. We've talked about Bell's a couple of times at this point. Now we're going to dedicate a few slides to it and talk about it in total. And then Ramsay-Hunt syndrome, I think we touched upon briefly. Optic neuritis, we talked a little bit with MS with that painful vision loss. And then lastly, Marcus gun pupil. Which one's that? Brought a knife to a gunfight. That swinging flashlight test, that relevant, the afferent pupil disorder. Cool. Here. And then we'll talk through the visual pathways. I know we flashed it before where we showed pictures of like, hey, if someone's eye goes out here, it's going to cause this type of vision loss. We'll go through that together. It's going to be a little bit scary section of the lesson, but we'll take it step by step and we'll get there together. All right. Cranial nerves, for the people that like to memorize, if they're sensory, motor, or both. I don't like ask you a single question. We're like, what's cranial nerve? I think that's foolish. You guys at this point should be able to say, hey, what's the clinical manifestation of this? But quick visual thing. All right, let's go into some of these visual fields. This is our, I know it was last on the list, but first on the topic. So just some anatomy for you guys. I got the eyeball, I got the macula here, working its way back. Here is the optic nerve. I got this little crossover section here called the optic chiasm. After that, it's known as the optic tract, and it forms these optical radiations that go all the way back to the visual cortex. Depending upon where that lesion happens, we can kind of see some of these different findings on the eyeball. And some of them look weird, where you're like, hey, why is this one donut shaped? Why is this one pie in the sky? We'll give you a couple of like easy ways to memorize where it's going to happen and just work our way down through. All right, so the first one, if someone comes in and they've got a horizontal defect, most of these ones throughout here are kind of like vertical defects because of the way your eyeballs and your brains, left side's handling what the right side looks like in both visual fields, and then opposite side for the other side. If anything's horizontal going across, don't think neurology anymore. Think an issue with the macula. Think of ischemia of the optic nerve. Think of issues within the eyeball itself. That's why it's up towards the front here. That's the quickest, easiest way to memorize this one is, hey, if it's only affecting the bottom half of the eyeball, imagine the bottom half of the eyeball filling up with water and not working anymore, or ischemia affecting from the bottom up. If anything is horizontal, think occlusion of the central retinal artery at that point. All right, the next one we can see is a complete blockout lesion. This is with number 2 right here. This is because that whole optic nerve affects this whole eyeball. That eyeball is going to look completely blacked out on that side. That's the only place it can happen, because as you move throughout here, it's going to break up into different sections. So number 2, I got eyeball completely gone, pretty straightforward. I'm thinking it's anterior to that optic chiasm before it crosses over and splits apart. That optic nerve, it's the only place where the eyeball is going to be completely gone or completely present. These two, you should be able to kind of work your way into them just from common sense. Does that kind of make sense to people, or is that kind of scary? Pretty commonsensical? Okay. And then this next one, you'll see this in clinic. I remember this one beyond anything else. It's called bitemporal hemanopsia. Have we heard those words before? No? Okay. So bitemporal, I think my temples, both sides. Heminopsia, hemi meaning half, opsia meaning eyes aren't working too good no more. The outside corners of both of my vision are gone. I've seen this in clinic a lot, especially with how common I've seen pituitary tumors. We start to gradually lose that portion of the outside of both. It almost kind of looks like tunnel vision as it's closing in. The patients aren't able to recognize it right away. Sometimes it's very subtle. Sometimes we have to do what's called formal vision fields testing. We can do this sort of maneuver and kind of grossly test it out. But they actually have these things called Amsler grids where they actually test out and say, hey, this side's decreasing compared to this side. So bitemporal heminopsia, it's pathognomonic, meaning, hey, I hear those words, I think optic chiasm being affected by the pituitary gland. There's other things that can cause it, but most commonly that pituitary gland is a pituitary adenoma. It's enlarged and it's pressing on it. And I'll show you a picture of what that looks like inside the skull so you can say like, oh yeah, there's it definitely pushing on it. It pops up in a slightly later side. Does anyone have a good feel about bitemporal heminopsia? Think bitemporal coming in, field of vision decreasing on both sides. And for those, this is number 3, that optic chiasm was where that crossover point is right there. All right. Next, this one, number 4 and number 6 line up with each other, so you could kind of lump these together. This is called hominis heminopsia, meaning it's not bitemporal anymore, it's both sides. So on my left eye and my right eye, the whole entire left side of my vision is out. This is caused in these optic tracts after the optic chiasm, because what happens is eyeball sees the whole field of vision, splits up to the right brain, splits up to the left brain. Breaks up those fields of vision. So think anything after the optic chiasm, it can cause that same sided blindness in both of the fields of vision. Another way to think of this, what a weird hemispheric sign where people ignore one half of their body? Is it neglect? Do we remember that term when we're dealing with like a hemispheric injury? My right brain, the whole hemisphere is affected, therefore I ignore the left side of my body. Think of that hemisphere with the cortex now. I'm going to ignore the entire left side of my vision because of my right cortex being affected. Does that help people make sense to correlate it to that? All right, here is one that is, we kind of clued into it before, but we didn't know what the terms meant yet. We talked about Myers loop briefly. I didn't really know what this was when I was in school. I was like, okay, sure, Myers loop, you win. What this is it's actually kind of like this looping out of that optic tract as it's going out. I thought of it as the scaphoid of the brain, and that kind of helped me a little bit because it's further out than everything else. It's that furthest one out. It goes through a ton of different areas of blood flow. It's further out than anything else. It can get injured physically. People love writing test questions about this one. It doesn't have a ton of other clinical significance other than it's the furthest one out that likes to get injured. Do we know scaphoid injuries yet? We are kind of familiar with those where that blood flows a little strange to it. It's not an exciting bone, it just likes to get injured a lot. Myers loop, hey, furthest one out likes to get injured, and I get a very specific pie in the sky. So it's going to be the hominis left superior quadratic defect. Think most commonly they're going to say, hey, upper left-hand corner or upper right-hand corner, I just can't see there. So pie in the sky, Myers loop, scaphoid of the brain. Does that work okay for people? Usually you're going to see patients describe a pie in the sky. They're not going to go through writing all these letters here because you'll just trip yourselves up trying to get that. I got a question over there. Number 5, is that what you were looking for? If they kind of marked it a little bit sooner, I think Myers loop, if you were to kind of take it exactly, would be right here. But as what we're saying is this optic radian going out, if the whole thing isn't affected, you're going to get a portion of that being affected. Most commonly, the upper right or upper left, because that's the furthest out. It's most prone to injury. And then number 6, this is kind of dealing with that cortical blindness that we talked about here. Again, if much like 4, if the whole thing's knocked out, the whole thing's knocked out here, I'm going to see that entire left or right side of my vision being affected because right side of the brain is affecting left side of the vision here. As you can see, I knock out that visual cortex, I take off that entire half of my hemisphere, I'm going to go to those hemispheric signs of neglect. I'm going to be neglecting my entire left side of my vision. And there's Myers loop for you guys. Big takeaways, if you're like kind of confused through those slides, just take your time through it. Don't try to memorize the crazy names. I'm not going to give you the weird hemispheric or heminopsia of this left, right. I'm going to show you images of what the vision looks like. And I'm going to show you this chart, and it's going to be like 1, 2, 3, 4. Which injury here produces this type of vision loss? Is that okay with you guys as far as testability? I know a lot of these terms are very difficult. Go ahead. Good. You're good with that type of question? Yeah, as long as you can say, hey, the patient presents with this type of vision loss, I'm suspecting a lesion here. Go ahead. No, I'm going to make it obvious because those things would be exactly the same. I'm not trying to trip you guys up like crazy. I'm just trying to say, hey, can you recognize a visual field deficit and try to localize it on an appropriate level? Yeah, well, I'll make sure we avoid invalid questions. I'm sorry? Did the juniors not hear me, or? Oh, I'm sorry. The question was for the juniors. Thank you so much. If I gave you guys a lesion and I say, hey, it's this one, I'm not going to give you 4 and 6 as answer options because you can't differentiate out based on both of those. I didn't give you enough information to say, hey, it localizes to here or here. It's going to be different options. Thank you. I appreciate the reminder. All right, Myers loop, scaphoid of the brain. All right, if we have an optic nerve lesion, so eyeball back, whole eyeball out, monocular blindness. Optic chiasm is going to cause that bitemporal heminopsia, meaning both of the sides of outside of the vision. That's the most common one I've seen in clinical practice. If we have that optical tract radiation occipital cortex, I'm going to get that contralateral hominis defect, meaning, hey, both sides of my eyeballs are affected the same way, either right or left. If it's the right side of my vision, which cortex, which radians am I expecting? Left, because it crosses over at that optic chiasm. Very good. All right, LR6SO4, I don't get a lot of utility. I'm not going to ask you a test question which muscle it is. Clinically, I just go straight to, hey, which cranial nerve's being affected, but just for people's memories, if it helps to know which one's which. All right, more LR6SO4. All right, you guys took Clin Skills 2 this morning, correct? Clin Lab. Okay. With these pupillary pathways and as we deal with light going in, a lot of times we talk about, hey, cranial nerve 10 controls my gag reflex, right? Sometimes we have to start thinking about efferent versus afferent, meaning things come in, causes a reflex to happen, causes things to come out. So when we talk about the pupillary pathway, think about that optic nerve 2 coming in, that efferent pathway 3 going out. Just know that sometimes 2 are affected. A lot of times when we boil it down to, hey, which is this testing, we're usually talking about the efferent, the outgoing. All right, when we deal with someone that shows up with sudden blindness, that's honestly one of the more common things that people present with. We were talking about MS yesterday, talking about people presenting with sudden monocular blindness. Drives people in ahead of any of those other findings. I can have numbness in my hand for years, but if my eyeball goes out, I'm going to the ER. Be ready to deal with a patient that shows up with that and start thinking, hey, what are the exact questions I want to ask? Don't be stumbling through, do you have a family history of your vision going out? Because then it feels kind of awkward. All right, if we have a sudden onset of blindness, think vascular. Those are the things that kind of clip out fast because we can have something that gets stuck somewhere, it's going to cause sudden loss. If we have a slow evolution of vision complaints, this implies more inflammatory neoplastic disease. What would be an inflammatory, what would be something that causes optic neuritis for us? What was one of those ones? What's that big ticket item we talked about last class? That, all right, all of a sudden I have vision that kind of comes and goes. I have difficulty seeing red now. MS, thinking optic neuritis. Okay. And then with these transient recurrent symptoms, painful monocular vision loss, optic neuritis. If I have transient painless monocular vision loss, I think retinal ischemia, amaurosis pugax. Have we seen this word before, or is this new and exciting? We've seen that one before? Have you seen its ugly brother, proctalgia fugax? Oh, that's a bad one. No, not in this class, but in a different one, pay attention. That one, I saw that in clinic a lot, and I was like, I don't know what this is. It's like, oh, proctalgia fugax. I'm like, okay. All right, and then painless progressive bitemporal vision loss. So bitemporal heminopsia, think optic chiasm compression. And then diplopia, inability to maintain conjugate gaze. All right, this is just talking through the complete visual system, physical. We all know how to do visual acuity testing, color testing, desaturations. You'll notice this when you deal with neurologists, that they'll have like their fancy reflex hammers, and on that tip of it, there's gonna be typically a red, it's always red. It's gonna have like a little point to it that's red. That's looking for color desaturation that we see a lot of times in MS. Clue that in now if I didn't hammer that home hard enough. We see color desaturation with optic neuritis. If red starts to get desatted and it doesn't really look vibrant anymore, think MS. We can do some visual field testings by moving our hands like this, and I've seen you guys do that. But also think about the physical portion of the eyeball. Actually examine the lids, look at the EOMs, the movements of the eyeballs, making sure they're not painful or painless. We think about convergence and accommodation. We think about position and alignment, just kind of looking at the eyeballs. And then what was the cranial nerve where we tilt our head to one side versus the other? 4, good job. All right, start looking at, have them move around a little bit and see if you can create that. Does it cause the eyeball to go up, down, right, or left? For 4. Up, up. And then pupillary reaction. And then we have the relative afferent pupillary defect. That's a Marcus gun pupil, right? Brought a knife to a gunfight. Asymmetric retinal or optic nerve disease. And then ophthalmoscope. Get good at that. I know they're hard to use here. They don't get any better when you get out. It's not like we dropped them on the ground a ton of times and we're just kind of staring. You just have to get very good at moving your body around and doing an actual good fundoscopic exam. All right, cranial nerve 2, the monocular vision disorders. We kind of talked about those ones real quick, but we'll spend a little more time on this. I got transient monocular blindness, aka amaurosis fugax. We got optic neuritis, which we've hit in MS a little bit. We'll give you a dedicated slide towards that. And then we got giant cell arteritis, which is one of those vasculitises, but I think neurology is the best place to teach that one initially. All right, so amaurosis fugax, that means sudden like darkness, or I think it means curtain when you actually translate it. And what happens is like all of a sudden your vision kind of drops like a curtain. I looked a little more into it, and it's not dropping vertically typically. When people say, hey, a curtain dropped over me, they're saying gravity pulls it down. In reality, it tends to occur across the eyeball from left to right. But sudden transient vision loss, decrease in blood flow to the retina, likely caused by some type of embolism. Treated as a TIA equivalent. These are emergency situations. Requires urgent vascular evaluation. And we have to look at the carotid artery and the cardiac for embolic sources. So start looking, think EKG, making sure this person's not an AFib and they're throwing clots. Because what can happen is a little tiny clot, you see that guy right there? Good luck trying to find that on a fundoscopic exam. But what we see right there is just a little bit of cholesterol that shouldn't be where it's supposed to be. Don't worry about remembering this Hollerquist plaque. I think that's just kind of a gee whiz. That's a fancy way to name it. Just know that when I'm dealing with, hey, sudden vision loss, is it painful or painless? Painless. What happens if it's painful? I'm thinking of different diagnosis, right? Optic neuritis. That's your big differentiator. Amaurosis fugax, painless. Suddenly just kind of goes out and drops like a curtain. Optic neuritis, and thinking more painful inflammation of the optic nerve. All right, dealing with optic neuritis, it's the inflammation of the optic nerve. What's the disease state this is really associated with? If you see someone presenting with optic neuritis or signs, symptoms of optic neuritis, what should we think? My guys and gals, you guys are doing great. All right, differential diagnosis, subacute, unilateral, usually vision loss associated, develops over a few days. When we say vision loss, it's not like completely out. It might get very blurry and we see that color desaturation. That's why you kind of see all these things described together. Pain is exacerbated by extraocular movement. So as I'm moving them through, they're like really close their eyes. A lot of people with headaches will present like that and they'll have blurry vision. You have to differentiate that out a little bit. And then the optic disc is usually normal. The classic thing is like, hey, doc sees nothing, patient sees nothing. Optic neuritis, I think, is a classic vignette people have talked about. Marcus gun pupil may or may not be there because that's not always a guarantee. Don't say, oh, but Marcus gun is there or not there. It may produce it, but it's not a guaranteed, oh, it has to be this or something else. But again, that painful monocular vision loss, pain with eye movement, reduced color vision, neurologist flips over the queen hammer and shows him the red tip and he says, that's gray. Start thinking optic neuritis. Start thinking a diagnosis of MS potentially. And then we have a picture of a optic nerve. I don't know if there's anything super abnormal. I think it's a little more red than normal. But again, the doctor sees nothing, the patient sees nothing. Fundoscopic exam can be normal in optic neuritis. Don't be looking for like a really inflamed optic nerve. There's nothing super specific about that. All right, workup that we'd like to see with this, get ophthalmology on board fast, get MRI of the head and orbits pretty quickly. And then we usually start these guys on methylprednisone IV. Do you want to send these guys outpatient, just chewing on some high dose ones? Probably not a good, especially if their vision's out, that's not a good, like, hey, go home, your vision's still good, but these pills will probably make a comeback. I would not feel comfortable about making that decision. Oral prednisone alone should not be used for classic isolated regimen because of the risk of recurrence too. We're not getting them up high enough to knock down that inflammation, and then they stop taking it, comes back even worse. And then it'll speed up the actual recovery, but doesn't substantially change the final outcome. Don't worry about that for a test question. Just know as you're like counseling your patients, like, hey, this is gonna make it great. No, it's just gonna make it come back sooner. Is that a value to the patient, like 1 or 2 days of vision? Absolutely. You telling me my eyeball's gonna be out? Do you want it gone for a week or 2 days? 2 days. I don't want to deal with my vision being gone for a longer period of time. All right, next one I have for you guys is something called giant cell arteritis or temporal arteritis. We're going to spend a little bit of time with this in the headache lesson in the next block, but we'll kind of introduce it here real quickly. What's happening is this temporal artery right here can get inflamed. Arteries aren't just like a tube, it's like a series of different levels of tissue that can get inflamed and cause a lot of problems when that happens. What happens here is when you look under a microscope, the cells look bigger than everything else, so they said, oh, it's giant cell arteritis. Sometimes you need to diagnose it by doing a temporal artery biopsy. Other times you can kind of do it clinically. Do you guys know ESR and CRP? Is it a painful point at this point? When do we like using those tests? Inflammation. Do we like ordering it a lot of times, or do we use it to rule things out? Is a negative test or a positive test more useful to me? Negative, because if I know, hey, I'm expecting temporal arteritis and I order a CRP on this, do I order ESR and CRP? I just order CRP every time. Yeah, do whatever you're allowed, because like you're not going to get one saying one and one saying the other, but CRP is usually the one I just default. I'm a CRP man. If it's negative, do I really think it's this? If it's positive, could that be because of anything? Just think of it, it could be anything. It could be artificially elevated because of X, Y, and Z. Just know that when you're dealing with tests, think about, hey, what do I do with a positive? What do I do with a negative? What are these things trying to tell me? All right, this can present with vision loss just because where it's located, a lot of those inflammatory products never like to stay in one spot. So it can kind of spread out and cause some issues with the eye, causes a ton of headache. You may see this kind of nodular You guys got me again? Oh, we're up. All right, sit back down. Today's a shorter, I think it's only like 66 slides, so we'll go until the 40, so you guys are offset break with everyone else, and then we'll finish up, and you guys will have a little extra time. And then we'll talk real quick about what we want to do for review. Cool. Hey, it's a hot topic nowadays. 50 question review? 51 question review, so it can't be traced back to me. I can do it. It doesn't do you any favors, though. You still got to take the pants. I can't give you a review for that. All right. It's a future problem for future us. They did their best. Okay. So, suspected giant cell arteritis plus visual symptoms. Start these guys on high-dose corticosteroids as well. Kind of the recurring theme here. If you get someone with vision loss, don't send them on the outpatient doses of prednisone. Keep them inpatient until vision comes back. Some of the symptoms that we see, it's not just like your normal, hey, I kind of have a headache. These guys have jaw claudication, jaw gets very painful, hard to swallow. They have headache, they have scalp tenderness, temporal tenderness, visual symptoms, throat pain. It kind of spreads out everywhere from there. But CRP useful for us to tell. If you need to, you can do a temporal artery biopsy. Do we do that while they're sitting in the ER? I wouldn't recommend it. That's going to be someone that's way better paid than us that knows how to handle taking a biopsy from a temporal artery. But that may come later. You may have to start treatment empirically and cases like this, where you're like, hey, his CRP sky high, I got vision loss, it's not really fitting a typical MS patient, he's 55 years old, I got a painful temporal artery that I can push on, I'm gonna treat it with the high dose steroids and call it temporal arteritis. That's very high in my differential. Okay, Marcus Gunn pupil, we beat it to death, right? Does everyone feel good about swinging flashlight test, RAPD? Okay, yeah, okay, cool. And what kind of like helped me memorize it, and get rid of the laser pointer. You see here, they're kind of doing the swinging flashlight test on him real quick to say, hey, something's not right with these cranial nerves. Pugilistic in effect, meaning someone beat the crap out of me to the point where that nerve isn't quite working right anymore, be it an efferent or their afferent pathway. Moving on, I think we've covered Marcus Gunn. All right, if you guys want to take a break, I got 32. We're halfway through the slides. We'll jump into the next one. You guys want to take a short break now? No, you want to keep going for 3 more slides? Take it at the 40? All right, we'll take it at the 40. All right, so we just covered the monocular vision losses. Let's go into some of the ones that can cause both sides of our eyeballs. We're moving back a little bit. We're still kind of on that chart that we were looking at earlier that showed, hey, this side, that side. First one I'm going to talk about is papilledema. Think more of the optic nerve at this point going into the eyeball. What can happen here is we can get an inappropriate amount of pressure behind, and that can push that optic nerve forward, also known as idiopathic intracranial hypertension, or IIH. This will pop up a lot on differential diagnoses. A lot of times you're thinking of younger women, overweight potentially, have a headache with a pulsatile tinnitus. Does everyone know what tinnitus is? Kind of that ringing in the ears. And then papilledema. So how do we see papilledema? Fundoscopic exam. We can see it on both eyes. We can see it on one eye, either or. Typically it happens both in a lot of cases. What does it actually look like? Margins are not sharp. So I got a couple of pictures here to scroll through to show you some ideas. So here's a normal one. So you're like, oh, that's scary. I'm not going to show you a picture of a fundoscopic and say, hey, determine this. That's meant for clin skills. Grade 1 papilledema starts to kind of poke out a little bit at you. And then as we progress through, we see more and more start thinking, hey, what's happening with these arteries? Do they kind of have like a weird bend where that's happening because it starts to poke out? And here you can see it like obviously looks like a 3D stricture or like a donut. We actually see a loss of the artery because it's like kind of going down vertically. We can actually lose those margins real fast. And then this one just kind of looks like a mess because now we're focused back here. This is, what's this dark area called? My man. As we go back through here, we start to see a lot of loss of what that focus looks like because again, we have a very narrow focus of where we're looking at. And then grade 5, I think it's like poking out at the front of the eyeball, like alien at you at that point. Yeah, no, at some point it starts to get gnarly. Don't worry about grading what papilledema looks like. It's more meant to show you a couple of examples and progressions. You just, like look in someone's eyeball, hey, do I see papilledema or not? And I've seen a couple of different examples at that point. But we can see some transient visual obscurations and enlarged blind spots tend to happen in this one. It doesn't fit a typical like, hey, is it this side, up, down, right, left. It's just that physiologic blind spot that we naturally have. You guys are familiar with the blind spot we naturally have? Where's that actually located? It's on the optic nerve itself as it's coming through. There's not a lot of like sensing stuff there. It all kind of branches out to the macula off to the side. When that becomes enlarged and pushes out more, it causes that physiologic blind spot to become larger and larger inside the eyeball. All right, papilledema. You guys good with that? Cool. All right, pituitary, as promised, I was going to show you what the pituitary gland looks like when it kind of gets enlarged. It's sitting in this like kind of centralized spot behind our nose and inside the bottom of the brain. Here we have that optic chiasm that was coming back, and we have this pituitary adenoma that's going up and it's pushing on that optic chiasm there. What kind of visual field deficit does that generate? Bitemporal heminopsia. Good. All right. If we got that down, you guys are slamming with this one. The MRI for this one, just for your clinical practice, you can get a brain MRI and they're going to say, hey, it looks enlarged, or order a SELA-specific sequence. Sometimes you'll have to send them off on the economy because it's like a higher Tesla MRI. They might need a specific view of it. But no, you can get a brain MRI or you can get a SELA-specific one. Just look for that, especially if you're like, you start with the brain and work down to the SELA. Can I order 2 MRIs at the same time? Yeah, why not? But just know there's like a SELA-specific one. Just in clinical practice, I was like, but I got the brain MRI. I was like, no, we need another one. All right. One of the things they can do, actually I had a patient I was working with, he ended up needing repeat procedures on this because his pituitary adenoma grew back somehow. Surgical excision versus drugs. We can have prolactinomas, that's the most common type because our pituitary gland releases a whole bunch of different stuff, right? What's some of the things that are pituitary gland? We haven't had endo, but I think we've had it during AMP. What's some of the kind of different things our pituitary gland handles? Growth hormones in there, I think. So we can see acromegaly in a few cases. I've seen that pop up, but most commonly prolactin. What does prolactin cause us to do? Lactate. Can it cause a guy to lactate? Oh yeah. Watch out for that. That's its own separate, like, all right, do I have unilateral lactation or bilateral lactation? Is it a man, woman? There's a whole separate algorithm for it. And you're like, I didn't think I'd see so many lactating people in my life. Pops up more than you'd think. All right. So we can either do surgical excision or we can manage with drugs. Most commonly, because we have that prolactinoma, if we're having a lot of lactation as a result and we don't like having our high prolactin baseline, they can get you on a D2 agonist. What's D2? Does anyone remember? Dopamine. Awesome. Okay, so we reduce that amount of prolactin because we're reducing that signal for it. This is called an endoscopic transsphenoidal surgery. This is what my patient had done to him. How long do you think it took him to recover? That's like going through his nose and like cutting the brain and stuff like that. He was up and walking around in like a day. He was doing great. He recovered super. I think he was out of the hospital in like 3 or 4 days, and then we were trying to get him up and flying within like a month or two. People recover from this very quickly typically. I know it seems scary because you're like, this is open brain surgery. People can recover from this one pretty fast. Does everyone need it resected? It's really based upon size. Up until 1 centimeter, a lot of times they just watch those. Endocrinology will tell you, hey, just have this guy come back in approximately every 6 months. If it's stable, every year. If it's stable, every 3 years. You'll see it extend out how quickly they want to do that. There's not a test question there, just clinical practice dealing with these ones. Not every single prolactinoma is going to require resection. What if someone already is starting to have vision field losses, that by temporal? Probably going to need surgery, correct? Good. All right. Let's take a break. I got 40 right now. Let's take 10 minutes. Some of the juniors are looking ready-ish. All right, so jumping right back into it. Sorry, a second ago we were covering pituitary tumors. Next we're going to cover some of those occipital cortex lesions. We were talking about cortical blindness a second ago. We were talking about, hey, this is some of those later affecting ones. Right side of my brain is looking at left sides of my vision fields. One of the things I wanted to point out to you guys, let me pull up my laser pointer again. If you'll notice, some of these images will always have this kind of like weird kind of donut hole cutout thing. For those of you guys who were wondering what was going on with that, a lot of times with those occipital cortex lesions, those tend to be macula sparing. It's just where your macula actually gets processed is a little bit different than everything else. So a lot of times we can get this weird vision field, but our central vision still looks good. That may or may not be in some of those ones. When we're dealing with cortex, it's not going to be a test question that's asking, hey, is it macula sparing or not? Just know that's why that image kind of shows up sometimes. And when we're dealing with cortical blindness, we're dealing with that posterior artery being the blood flow to that. Just know that sometimes I can get macula sparing. Is macula sparing good or bad? Like for a patient? Good. If it spares my macula, I still have that very fine vision fields. So a lot of times, even though my peripheral vision is kind of junk, that macula being spared, that might not drive people in right away because my eyeballs are still super useful to me. It's just kind of blurry up in this corner. All right, cranial nerve 3, down and out. We all feel very good about that now, right? As far as identifying that. The question is, all right, he's down and out. What does that tell me? What do I need to do about that? So the thing that we need to pay attention to is whether or not it is pupil involving or pupil sparing, because that a lot of times down and out might not always have a lot of out being, or excuse me, might not always have the pupil blown out completely. If we have a new onset of cranial nerve 3 palsy and pupillary involvement, I got to rule out a cerebral artery aneurysm. The reason being, as that cranial nerve 3 comes out through here, it's actually a very easy pinch point for that posterior cerebellar artery, or excuse me, that posterior communicating artery. We were talking about the circle of Willis. Do you guys remember where that was in the brain? Like towards the veins, but he's pointing, it's a circle. It's like down towards the middle. What's a really common thing that happens there, especially in those communicating arteries that branch point? Aneurysm, that's the number one spot those things can happen because the branch point likes to blow out. It can happen here, and that will cause that cranial nerve to kind of go down and out. So if it's pupil involving, think compressive aneurysm, and if it's pupil sparing, still think microvascular ischemia. Pupil involving, if more things are involved in this finding, this cranial nerve 3 down and out, it's more scary. Start thinking, hey, I have to watch out for aneurysm in this person because of where that nerve actually travels. So pupil involving cranial nerve 3 palsy is a compressive emergency until proven otherwise. Specifically, that posterior communicating artery, don't worry about naming the arteries of the circle of Willis. There's so many things to learn. I don't want you guys to name anatomy here today. But just know when we think circle of Willis, we think aneurysm. One of the findings could be a cranial nerve 3 palsy. And you're like, wow, that's a weird connection. No, it's running right through there. It's very easy for it to press on it. And there's just a very classical picture of what a cranial nerve 3 palsy might look like. Did they always present that far gone? The image we present you guys with are meant to show like the extremes because they're easy to recognize and they stick in your brain. A lot of times we can have more subtle findings of it potentially. All right, does anyone know what anisocoria is? Have we talked that term yet, or is that a brand new we know? Does anyone have anisocoria? Like 2 different sized pupils? Have they found it when you're kind of doing physics exam and that guy just looks a little weird compared to everyone else? It can be a normal physiologic find. Does anyone not know what anisocoria is? It's 2 different sized pupils, and that can be caused by a lot of different things. So sometimes it's congenital, we've had it the whole time. Sometimes it's not. Like trauma, recent, now we have 2 different sized pupils. Don't say, oh, he's always been that way. What's a quick, easy way to tell if someone's always had it or not? Pictures are a really good baseline because a lot of times people don't know they have anisocoria. One of my old medics in my clinic, like his pupils were 2 different sizes and he just always looked around. We're like, are you okay, man? He's like, yeah, I've always been this way. Look at old pictures. It's hard to see that on a driver's license. Just have the wife take out the phone. People never take pictures of themselves. It's always the wife that has pictures of them. I'm going to go through this chart. I don't want you to memorize it. We're going to go through this one. It's a little more confusing for me. I never really understood it as a student. It's still there. I'm going to leave it for you. I boiled it down to this. Just pay attention to this slide and it'll keep you straight as you're moving on. This is going to stick in my brain. So if I have anisocoria, meaning my pupils are 2 different sizes, I'm going to put them in the dark, I'm going to put them in the light. If my anisocoria is greater in bright light, so I put them in a bright room and hey, the pupil sizes are much more different than they were before. The larger pupil is abnormal, I see a parasympathetic cranial nerve 3 problem. And if my anisocoria is greater in the dark, so I'm in a normal room and I bring them in the dark and then the pupils are even 2 different colors, my smaller pupil is the abnormal one. I'm starting to think more sympathetic or Horner's pupil, which we'll talk about Horner syndrome in a little bit. Can you guys keep those 2 kind of separate? If I put them in a bright room and it's worse, I'm thinking rest and relax, parasympathetic. If I put them in a dark room, dark, scary room, sympathetic response, I'm thinking, hey, it's something on the sympathetic pathway. Here's the chart. This will be very helpful in the future if you're in clinical practice and you're like, hey, I have an abnormal pupil on this guy. I don't know how to work this up or what category he fits in. I just know if he's in a dark room, it's scary, therefore sympathetic. This will walk you through, and there's a ton of these in UpToDate. When you're dealing with stuff like, what's the name of the AI one that we're using now? Open Evidence, it doesn't put you through these pathways as much. But when you're dealing with UpToDate, they'll have pathways like this one. Don't worry about memorizing this one, just keep it in your pocket for future practice. And then here's kind of this chart. I always had a hard time differentiating out like the different sized pupils. It was just trying to walk you guys through, hey, put them in a light room, put them in a dark room, determine if it's parasympathetic or sympathetic. So if it's sympathetic, we start thinking of something called Horner syndrome. I asked this question among a bunch of doctors and PAs that have been in practice for a little bit. Everyone can always recognize Horner syndrome as being ptosis, meiosis, anhidrosis. It's this weird rhyming Dr. Seuss spell that we just say, oh, I recognize this every single time. Does everyone know what ptosis is at this point? Droopy eyelid. Does everyone know what meiosis is? Constrict. And then anhidrosis, do we know that one? Lack of sweating. How many people present to the ER with lack of sweating? Few. I don't think anyone ever said, hey, this half of my body stopped sweating, what's going on? They're going to present, they're going to have an abnormal pupil, and you're going to go in there and you're going to look. That patient may or may not have a different size, a different colored face on one side. It may look red compared to the other side. What's the thing that our sympathetic nervous system does for us? Fight or flight. So what are important things when I'm dealing with eyelids? Those should be wide open, right? So think sympathetic with that. Do we want our pupils dilated or constricted? Dilated, so we can take more light in, we can respond to that tiger. And then when we're freaking out, we got the nervous sweats, right? We like to sweat because that's our body's way of cooling itself down. So just think of those findings being something that's sympathetic. All right, pupil enlarged, we have sweating, and we have ptosis. Why do we have the opposite of this? Because that sympathetic pathway is not there anymore. So instead of being activated, I have a droopy eyelid, I have a very small eyelid, and I have no sweating because now my parasympathetic is presenting unimpeded. Most providers will be able to tell you ptosis, meiosis, and hydrosis. If you ask questions beyond that, like, okay, you have this classic trad, congratulations, a lot of people don't know what to do with that because it doesn't present that often. We'll talk through that real quick. Don't worry about knowing these different tests or trying to identify these different ones for the sake of this. For the sake of our test, I want you to be able to recognize Horner syndrome and that the fact that it can be either second or third order. So what we like to do with these ones, we actually break out the good drugs for this one. You can confirm it with cocaine eye drops, and then you can tell if it's pre or post with amphetamine eye drops. So you know you're dealing, don't order them unless you need them, but the ophthalmologist is gonna come down with the good stuff. So what they can hit them with is this thing called hydroxyamphetamine. It tells you if it's either pre or post ganglionic. Pre or post meaning, hey, is it happening before that sympathetic ganglion that's happening there, or is it happening after as it gets to the eyeball? And pre-ganglionic, when I provide them with the eye drops, I should see it correct. Post-ganglionic, if I provide them with the eye drops, it's not changed. I think it's actually due to a third order issue. I know this is kind of confusing. Don't memorize this slide for the test. It's a lot of tests that providers out in practice don't know how to work themselves through. I want you guys to be able to recognize, hey, I have to do something other than say, hey, it's Horner's. No, I need to call ophthalmology. We have to figure out if it's two different things. So the two different things that matter, if it's a second order, so coming down from the brain up until the point of being that preganglionic lesion, we think shoulder arm symptoms, preganglionic lesion, we have to look at the apex of the chest because we can very classically associate it with a Pancoast tumor. That's a lung tumor that happens towards the top of our lungs. After that hits that ganglionic pathway and it goes out from there, we can see acute painful ganglionic Horner syndrome. We need to evaluate them for a carotid artery dissection pretty quickly. So your takeaway from this, because I know that's a very confusing, a lot of different tests. I had to work my way through it because I knew ptosis, meiosis, and hydrosis. I didn't know what to do next. I had to look these tests up and say, all right, we have to teach this. If I see a painful acute Horner syndrome, so not sweating on one side of the face, pupils a little bit small, and the lid's kind of lagging down and it's painful, think carotid artery dissection. Does that work for what we need to know? I know it's kind of confusing. There's a couple of different pathways. We're not going to go too hard into Horner's. Recognize it and know what to do when it's painful. Are you guys good with that level of detail? Sweet. All right, Argyll-Robertson, right? Argyle socks, business socks. What do we associate this one with? Syphilis. Are people going to come in with Argyll-Robertson pupil? You're probably not going to recognize. There's probably going to be other signs that someone has neurosyphilis at that point. Like for a classic historical vignette, I know Mr. Rekowski loves doing these ones. What was the gangster's name? Al Capone. Classic case of neurosyphilis. It got so bad to the point that his fellow gangsters were like, man. They actually allowed him to get arrested because he was just acting so bizarrely. Does anyone know for like bonus points? I'm not gonna give 2 points on your test. She won't let me do that. Does anyone know what his name was towards the end? He was demanding that his fellow, his henchmen call him Snorky. And we're like, I'm not calling you Snorky. And it's like, it's Al Capone, you kind of have to. But he had a lot of very bizarre behaviors towards the end. That being said, you're not gonna recognize someone having Argyll-Robertson pupil and do this whole workup and say, oh, turns out you had neurosyphilis the whole time. Because then they were like, yeah, look at all these other weird behaviors I've been displaying. There's a ton of other findings you should get before that point. All right, Addie's tonic pupil is this last one I want to pay attention to. This one is a unilateral dilated tonic pupil. Does anyone know the term tonic? kind of like atonic. It's not really flexing properly. So the poor light response constriction, especially near accommodation, it's associated with deep tendon reflexes and Holmes-Addy syndrome. Don't worry about memorizing that. It may often be an idiopathic or benign finding. This ends up being one of those weird diagnoses that you kind of end up with when you're dealing with, hey, I have an anisocoria, which way do I chase it down? And it just ends up being an Addy's tonic pupil. One side just doesn't react quite the same as the other ones. It's just kind of slow and sluggish. This is one of those safe diagnoses to end up. Horner syndrome, hey, I'm looking for tumors and or carotid artery dissection. If we end up down that pathway and we say, hey, this eye is just a little more sluggish than the other one, it may be one of those, cool, you've got Addy's tonic pupil. There's nothing too much more crazy. It's one of those safe diagnoses to end up with. And then comparison chart for you guys, because I know we talked about a lot of different examples of why pupils can be normal, not normal. I know it's kind of hard to tell, like, hey, this one's enlarged, this one's not, so don't worry too much about the images there. I tried to get it cleaned up a little bit, but it has a lot of the associated findings that we see with these ones. So Addy's tonic pupil, think younger women, think, hey, minimal dilation doesn't really respond correctly. And it's pretty idiopathic, meaning, hey, there's nothing really causing it, or we're idiots and we don't know why. But viral illness, trauma, it's not necessarily something that's scared that needs to be worked up like crazy. Argyll-Robertson pupil, what's the pathognomonic for that? Neurosyphilis, correct? Sorry, we know the term. Yeah, you guys know. That wasn't a trick question, I apologize. So small irregular pupils that accommodate or don't react. I don't think I actually described what it is. Has anyone ever heard the term prostitute's pupil before? I got rid of the language from that. I know it's a little bit offensive. I'll at least bring it up. So it's the idea that it accommodates, but it's not really reacting to it. I wanted to step away from that language, but I don't want it to be something you're like, other classes have this cool mnemonic that I can't use. I'm going to gradually phase that one out. You may see that in your future studies, but we try to avoid using language like that. Okay, and then Horner syndrome. What's the Harry Potter spell for that one? Ptosis, meiosis, and hydrosis. Congratulations, you're as smart as every other provider in the United States of America. Now, what do we do if we get that? We're thinking if it's painful carotid artery dissection, and we're breaking out the good stuff, the amphetamine drops, because we have to determine if it's pre or post-ganglionic. All right, anisocoria is kind of like this overarching term that describes all of them. That's just two different pupils. What happens if I do someone with anisocoria, I put them in a dark room, and it's worse? What does that tell me? Is that sympathetic or parasympathetic? Sympathetic, because the dark is scary, so our sympathetic system's involved. And then what if I put them in the light, it's worse? Parasympathetic, very good. And then cranial nerve 3 palsy, down and out, you guys feel pretty good about that one, right? What happens if I have down and out and it's painful? What am I worried about? Aneurysm, because it's going right past that circle of Willis, that posterior communicating artery, and it's a very common choke point for there. All right, cranial nerve 6 palsy. We kind of talked about this one before. I'm just going to hit it again real quick, not to belabor the point. But at this one, we're thinking the eye's a little bit higher than the other one, and we can worsen it or make it better by tilting our head. If I tilt my head to the right and my right eye is affected, is that going to make it better or worse? 4, sorry, I can't read. Appreciate you guys. Is that going to make it worse? Worse. And then I tilt my head to this side, that's going to make it better. So if I see someone come in, younger kid, kind of has the tilt head always to the side, and finally you straighten out their head, and the eyeball goes up a little bit, we start thinking that may how it present, because we tilt our head to the side to kind of correct that a little bit. And then we start talking about the different flavors of diplopia. We can have that horizontal where two things look like they're separated like that. We can have this mixed version, but this one we're very specifically seeing that vertical diplopia because that eyeball's coming up a little bit. We think of the German Shepherd for 4. LR6, SO4, I'm not going to ask you the exact test question, identify this muscle. I care about what things actually present as when I see the cranial nerve dysfunctions. All right, and then here's just an image, if it helps you guys as far as, don't worry about the AB or A deduction. I like really tilting the head to the side as the quickest, easiest way to kind of see that pop up. But normalize on this side. Affected eyes here, we see it a little bit higher than the other side. So when I tilt it to the affected side, it's made worse. And when I tilt it away from that side, it goes up, it becomes better. Is everyone good with that? Cool. All right, cranial nerve 6 palsy. Can anyone tell me what that looks like? As we're kind of going across here, the eyeball is going to get stuck potentially or kind of lag out a little bit. So it's the inability to abduct the ipsilateral eye, producing an esotropia and horizontal diplopia. So cranial nerve 4, like the vertical, this one, because the eyeball's not going out or might be getting stuck, it creates images that are separated out in that same field of view. It's important to ask the question when they have double vision of like, hey, does it look like they're on top of each other or they're side by side? It's easy to differentiate that. And then what's the thing I'm worried about, especially if someone presents with this with bilateral or it's severe or maybe they have head trauma? What's the thing I'm worried about? ICP, because it can potentially push in that nerve as it's coming out. I pulled up a picture here because I like visualizing things and understanding like, okay, where's it actually getting pinched up at? So I got this abducens nerve. Here's the bonus point of the year right here. Where's this nuclei located? What's 5, 6, 7, 8? The pons, good job. All right, so I got this nuclei here. It's coming out through. It's very easy for this to get pinch point here, especially as this gets forced down. And that's going to cause that eyeball not to go out. So that's why that pinch point's going there. And just for spelling's sake, we got uncle herniation versus uncle herniation. This is your uncle, he has a hernia. That's not life-threatening usually. But uncal herniation, if you say uncle herniation in a note, they're just going to move on. It's going to be okay. And then I have an image here just kind of showing you of what that palsy might look like. As we come out to the right, as we come left here, we see that eyeball getting stuck, correct? Everyone can identify that from a mile away. It may present kind of differently as you move through conjugate phase. It may kind of like get stuck a little bit going up, but end of the day, just look for that lateral motion getting stuck. And it may be subtle. It may end up going there, but it may lag a little bit. All right, trigeminal neuralgia. This is a very important one. You're going to see this in clinic a lot. I'm going to ask a test question about it. So trigeminal neuralgia is this painful lancinane distribution, especially on the cranial nerve 5. It can exist in 3 and 2 typically. Where's 1, 2, and 3 on my face? 1's at the top, right? Because that's the lower number, so it's lighter. All right. People just randomly develop this sometimes. It's really unfortunate. I couldn't say, hey, here's the very typical patient or here's the risk factors associated with it. But very painful shooting down, typically on one side of the face, brief seconds, approximately 2 minutes, so it just kind of goes away, comes real fast. It's not that constant. Think TMJ if it sticks there for a long time. But trigger zones may be activated by touch, brushing air, chewing. I see like wind, like going outside, end up being like a really common trigger point for these people. It's a compression of the trigeminal nerve by a blood vessel sometimes. Other times I've worked people up to the point where they're like, hey, there's nothing actually wrong with the nerve, it's just angry and irritated. There's nothing actually pushing on it. ESR, CRP is going to be normal. What if these were elevated and I have a lot of temporal pain? What's that diagnosis I'm worried about? Giant cell arteritis, especially with vision loss. Should I expect vision loss with this one? No. So it's that brief electric shock-like pain. It happens in a trigger zone. Normal exam, I think trigeminal neuralgia. I've seen a lot of younger people be affected by this, and it can be pretty disabling. It's not nice when your face just like randomly turns to fire every so once in a while. Some people recover spontaneously, like the acute episodes, you don't have to take Tylenol or naproxen to deal with it. Sometimes you can end up in the ER if you have kind of prolonged period. But the drugs that we'd like to do they're actually anti-seizure medications, so they affect the sodium channel blockers, so we're trying to reduce how likely it is that we're gonna have an onset of this pain. I can deal with carbamazepine. Thing you have to watch out for that one. I'm not going to test you on side effects. You get that enough in pharmacology. But you have to watch out for agranulocytosis, which means low white blood cell count. So make sure you're watching your CBCs and your LFTs. And then triliptyl is the other one. No one calls it Oxcar. They all call it triliptyl. This one you have to watch out for bone marrow toxicity. I've seen more people, they usually start them on carbamazepine, and then they end up on triliptyl after they don't tolerate it. They end up being drowsy more than anything else on this medication. What's another like neuropathic medication that we can try on these people? I know you guys have been beaten up. I'm just kind of thinking clinically, not quizzing you on your farm knowledge. What works well for neuropain? Gabapentin, pregabalin, and pregabalin, I like that a little bit better because it's a little less drowsy effects, even though we kind of start dealing with controlled medications. Make sure you get a brain MRI on these people. The reason being, just to know like exactly what that nerve looks like and what's being pressed on. You can have this superior cerebellar artery as it's coming through right here. It can push on that, and as it pushes on that nerve, it irritates it, causes it to fire. That's what causes the pain to happen. And actually can put a Teflon pad in there to block that. Of everyone that I've had it, they didn't end up having like a very clean morphology to say, oh, let's go put that pad in there. It's going to clear that up every single time. I kind of default to the neurosurgeons at that point to say, hey, is it an option? Of the people I've had with it, we ended up just managing medically. Ended up being an MEB for most of them just because you can't have random disabling face pain that keeps you from going outside over a long period of time. All right, which cranial nerve are we thinking? So when we scrunch up our face and that eyebrow's not going anymore, is that a good sign or a bad sign? The rock. The rock don't hear no bell. We start thinking Bell's palsy. If someone has, is it forehead sparing or not? Those are the things we think about. If it's forehead sparing, aka both sides go up, we start thinking more stroke-like lesions. Bell's palsy, it's reassuring to have that eyebrow. Can everyone see how this eyebrow is not going up anymore? Does everyone understand what's actually happening? We have facial droop here. She's asked to smile here, so this mouth is going up. This looks normal. This eyebrow, not really moving. This eyeball looks a little more open. We see kind of the mouth drooping. So you guys can see how this palsy is involved. Sorry, I didn't pull these things out. Now when we ask them to scrunch up the face, what's happening to this eyebrow? It's raising up a little bit, right, compared to the other side? Can you guys see that, or is it really subtle? This is kind of like a medium level difficulty, not question, but just like patient presentation. They might not be super obvious every single time. Can you guys kind of tease out where that palsy is then? All right, so Bell's palsy, cranial nerve 7. For whatever reason, this pops up in the ER a lot. What happens when we have a facial droop? Do we go to the ER generally just from like common sense? We start thinking stroke. It drives people to the ER a lot of times. So it's going to be that same-sided weakness of the entire face, including the forehead. What if it's forehead sparing? We start thinking more stroke, more central lesions. So other things, you can have hyperacusis. What's that mean? Sensitivity to sound, everything's just super loud. Decreased lacrimal. Why is that important, the decreased lacrimal? What happens when I have ptosis and my eyeball isn't quite closing up anymore? Get dry eye, it can get very painful over a long period of time. We can get loss of taste over the anterior 2/3 of the tongue. I haven't seen that a ton in Bell's palsy. It tends to be the facial paralysis that drives people in. More common in women and diabetics. I'm sorry, you got it. Oh, it's flexing. It tends to pop up super fast. I know those are always really concerning for vascular lesions, but this one is not vascular in nature. It's more inflammatory. Sudden onset, max weakness in about 48 hours, and it just kind of resolves spontaneously on its own. Sometimes people can have pain behind the ear before it erupts. I haven't seen that a lot of times. Bell's palsy, again, we have that eyebrow going up. We think the rock is inside a wrestling ring. There's a bell outside the ring. The rock's listening for the bell. Does everyone get that correlation? Cool. All right, so lower motor neuron, cranial nerve, 7 lesion, forehead not spared, aka you're going to give them the rock. If we have that central lesion, the forehead is often spared due to bilateral cortical innervation. Just know, hey, the way the nerves are connected, think cortical if the forehead is spared. All right, treatment for this one, prednisone can help. It's not always necessary, but it can kind of shorten the duration of it. The big thing that we're working on is making sure this eyeball isn't drying out. We feel pretty confident that these people are going to recover on their own, and usually if you tell them that, they're okay with that. But what are some ways that I can keep this eyeball kind of moist in the meantime? Artificial tears, there's actually a thicker version of it that works really well. Just grab like the 1% versus the 0.5, or I forget exactly what it is. Just know that there's like a Celluvisc, there's a thicker version of it, reach for that one. What about erythromycin ointment? You can. That's a very common one that we do a lot of times just because it's like a very sterile version of like a petroleum ointment, but that can keep that eye from drying out. What if someone has it chronically over like a long period of time, like ptosis caused by other things? Taping is a very good option, and you could give them some clean tape to do that. You guys have had ENT a little bit. One of the things they can actually do, as my previous surgeon ended up having this done, was they inserted gold weights into his eyelid to help kind of close that down a little bit. They're also called a tasselraphy, where they help close that eyeball up surgically a little bit and kind of correct for it. All right, antiviral therapy, maybe kind of hit and miss, but always make sure we're sticking to corticosteroids in this person. So the biggest things when you see Bell's palsy, one, finish the stroke workup because a droopy face, don't just base it off of on the steroids to kind of shorten the course of that because that's meaningful to people, and making sure we're protecting the eyeball so it's not getting dried out over a long period of time. All right, I got one more one. We kind of talked about this briefly. What was it called when I had herpes, but it ends up affecting my nose? What's the name of that sign? Do you guys remember that one? What am I worried about when it's affecting my nose? Cranial nerves, what can potentially be involved with this one? Eyeball. It's called Hutchinson sign. And then we're worried about the eyeball being affected. Don't worry, we'll talk about what we're doing for the review in a second. So Hutchinson sign, point of my nose is affected by that. I start worrying about the eyeballs. I get ophthalmology on board sooner. Other place where I can get shingles and it affects my ear is called Ramsay-Hunt syndrome. So think the herpes zoster oticus involving cranial nerve 5, 6, 7. It can cause that facial weakness like Bell's palsy tends to be a lot worse. Think, hey, if I get herpes vesicles inside my ear, what's the thing I'm worried about being lost now? Hearing. It's not a very far jump to move down to say, all right, it's affecting the whole nerve. It can move down to cranial nerve 8, cause a lot of vertigo symptoms, and it can cause sensory neural hearing loss at that point. MRI can show the affected inflammation of cranial nerve 7, nerve conduction study. Probably not doing a nerve conduction study of someone's face. Try to avoid doing that if it's like a clinical diagnosis. But you can treat with antivirals. That's going to become more of a mainstay. And corticosteroids. So as opposed to the other one where it's like Bell's palsy, we don't know exactly what caused it. Maybe I can consider this one. When you see herpes, get them on the antivirals immediately, as well as the steroids. And just to kind of close it up, we're moving on to a different one here, sorry. Does anyone have any questions about Ramsay-Hunt syndrome? Okay. And then one other issue, this is a really common one I've seen in clinical practice. Has anyone ever heard of an acoustic neuroma before? Did that come up during ENT? Yeah, to the point of exhaustion. We'll cover it real quick together, just one more time to hammer it home. You'll see this pop up a lot of times when people go to get their hearing done, and then they show back up to you and say, hey, the neurologist or the audiologist said I have sensory neural hearing loss, it's unilateral. You're gonna get a brain MRI on these guys to make sure they don't have what's called an acoustic neuroma. Is an acoustic neuroma like really bad? Maybe. It's benign, typically in most cases. I'm not super worried about being like metastasis and spreading to other areas. But it can cause that compression of the acoustic nerve as it's coming out and cause that sensory neural hearing loss. Not everyone's going to need a resection of this. Some people, they just kind of watch it over a period of time to make sure it's not growing. If we have that hearing loss, they can try to debulk it a little bit and remove it, but it's still kind of a naturally outgrowing portion of that nerve that's causing issues. So one guy that we ended up taking to surgery, he did not get back his hearing after they attempted to debulk. Weber's and Renee's test, just for your reference. I'm not going to ask you a Weber's and Renee's test. You guys feel pretty confident doing that from Clin skills and a GNT to localize a lesion. I know we do it and we're like, oh, it localizes to the left, great. Now we care about localization because we're trying to figure out, hey, this is in the brain where it's causing issues. But there's nothing new and exciting with Weber's and Renee's for you guys. I'm not going to ask a question on that. All right, gag reflex. What cranial nerve covers our gag reflex? 9 and 10. 10 because we care about, all right, what's actually causing it to happen. And when I have someone open their mouth, does their uvula point towards the side of the lesion or away? Away, because that side's drooping down, it's going to cause it to point to the opposite side. Now, tongue is a little bit different. Can't push a rope, right? When we push out our tongue, what side does it deviate to? Towards the lesion, because that other side of the tongue that's normally projecting out isn't quite working right anymore. It's going to push you towards the side of the lesion. Right. And then tongue points towards, I think we covered all of that, good. There's just kind of a more subtle finding of a tongue palsy. Like, I don't think he's actively like pointing it out as far as he can go, but you can see how, hey, this side has tone, this side does not. Does that kind of make sense to you guys? I'm pretty sure that's what they're trying to show us here. If someone has a really kind of asymmetric tone of the tongue, pay attention to that as well. And then what was our trick for cranial nerve 11? We feel pretty confident about spinal accessory nerve. We're testing strengths by pushing our chin to both sides. What's the weird little trick with this? It's the opposite. It's because of where it's attached. Think SCM muscle going up towards the back of the head. As that shortens up, that's going to push my head to the opposite side. So think about localizing the lesion that way. Is that the same thing with the shoulder going up? No, that's common sense. It's just this muscle going up there. Don't let it trick you and say, oh, the whole thing's reversed. All right, Altered sense of taste, just know that a lot of the different cranial nerves, I don't expect you to remember, this one covers the anterior 2/3, this one covers the posterior third. A lot of people don't show up with loss of sense of taste. You involve cranial nerve 1 at this point because if your smell goes out, that's a little bit weird too. Just know that a lot of different cranial nerves kind of cover taste. I'm not going to ask you to differentiate out a cranial nerve by localizing it to where the tongue can taste or not taste. That's not a reliable exam finding you're going to use in clinical practice. I thought what was weird, just kind of gee whiz, like cranial nerve 5 doesn't exactly carry taste, but it's actually like controlling like spicy foods. So that's why your face turns completely red whenever we're dealing with like really spicy foods happening. I thought that was kind of interesting. But. All right. Does anyone have any questions? If not, let's talk about what we want to do for review because we got 2 lesson blocks left, but we're done. So, which is good. Was that a ton of stuff or a little bit? Are we scared? Neutral. Well, it's 2 exams. So it's scary. Neurology is weird. I know it's like a ton of disease states, but you guys are used to that, but they're all kind of like very weird like ways of saying things. I will kind of clue you guys into what we want to do during the review. It's not going to be a 50-question review, but it will help because you guys have a lot of questions. You're like, what tiny little details do I need to pay attention to? I'll help kind of get you guys and guide you into like the big topics, and then I'll phrase a couple of questions as like, hey, here's the different optic pathways. Here's what it's going to present as. You're going to get a question like this. Is that an appropriate level for you guys to like, hey, I feel comfortable with that. I can't hand you 50 questions. That's no bueno. Cool. We'll plan to do that. I'd like to do that with you guys tomorrow during that block. Is that okay? I think the juniors, we're kind of leaning towards that. We still have this one extra block where I don't have anything planned yet. I know for the juniors, they've already done clin skills and gotten a chance to practice the neuro exam. I know you guys, I taught you how to do it, but we never sat down with the checklist and actually did it. I didn't realize the lab blocks were that far apart. Is that correct? Would you guys feel a lot more comfortable getting a rep in of a neuro exam before going into the test? There's not going to be like, oh, here's this very specific thing. Would you want to get that beforehand or not? No, too much extra? My feelings won't be hurt because now I'm kind of doing revision of the syllabi. It's because you guys would normally have this down and going over the physical, like doing the neuro exam, I realized you guys were disadvantaged at just not having a few reps in and having been tested on it yet. We could potentially, let me see, I'll float the idea out, get with Carrie, like give me a, hey, here's the interest signal. If it's only a few people, sure, I'll do it anyway. Let me make sure I can grab the space to actually do it, but we could potentially do it pretty short, just run through it and not have you guys like sit through over long. I can demo one for you even if you didn't want to like do it. You just want to demo it together? I don't hate the idea, and it can be optional for everyone else. They can pay attention or not pay attention. Is that a little more better for that block? Because you guys are in during that day anyway, right? Okay, so let's just plan for me to demo a neuro exam. For the juniors, I'm not going to hide any test questions in there, but if you want to come over and watch it, that's perfectly fine. Other than that, I won't have anything for the juniors. If that is good, you guys all, I got one more question. Oh my God. We went over the ones today, right? I'm not crazy. You want me to post them as the bonus content? Coming up in like 5 minutes. Anything else? All right, appreciate you guys.